तुम्ही तिथे निवडला
Hello. Hello.
Yes, you are audible, Ankush.
Yes, sir. Yes, sir. Good morning to all. Suprabhatam. Myself, Dr. Ankush Dikondwar, Organizing Secretary for this event. We are starting this particular webinar series on pathology to enhance and update the knowledge of Ayurvedic Vikruti Vigyan PGs as per time. Our today's guest speaker is respected Dr. Pratibha Davande Madam. Before I call her for the guest lecture, I would like to invite our spokesperson, Dr. N. Ambishia Madam, to introduce our organization, RVPGA.
Thank you, sir. Namaskar and good afternoon to all the respected Ayurvedic fraternity and dear students. I am very much delighted and gratefully obliged to Dr. Subhash Wage sir, Dr. Santosh Chavan sir, organizing committee members, and Dr. Ankush sir for giving me this honor. As we all know, RVPGA doesn't need any introduction as such because of its magnificent and vibrant activities. But it's my pleasure to reacquaint briefly about our organization in this wonderful, super exciting series. RVPGA, Rognidan Evam Vigardi Vigyan PG Association for Pathology and Radio Diagnosis, formed in the year 2016 under the able and dynamic leadership of Dr. Subhash Wage sir, with the aim to give the legal status of pathologist and radiologist to the PGs of Rognidan. It is the only organization which is fighting for the lawful rights of Rognidan PGs. Even the NCSM had also directed State of Maharashtra to consider RVPGA as a stakeholder in the constitution of pathology regulatory body of the state. The organization is also constantly trying the implementation of NCSM salary structure for all the private colleges across the nation. IJD, International Journal of Diagnostics and Research, RVPGA, are the recent brilliant initiatives. Day by day, our organization is branching out thanks to the selfless activities of our leaders. For the Library web series, webinar series, and the future endeavors. Together we can be our motto. Thank you once again. Thank you, sir.
Thank you, madam, for introducing our organization. Now, I would like to invite our president, respected Dr. Subhash Wage sir, to welcome our today's guest. Over to you, sir.
Thank you very much, Ankush. I heartily welcome Dr. Davande Madam for readily accepting our request and coming to our dais for giving the knowledge to our coming postgraduates. I thank you very much from my heart, and I welcome to this program once again. Thank you, and you can proceed further, Dr. Ankush.
Thank you, sir. Now, before inviting a guest speaker, Dr. Davande Madam, I would like to give introduction of ma'am. Respected Dr. Pratibha Davande Madam is a professor and HOD in the Department of Pathology at Datta Meghe Medical College, Banadongri, Nagpur. Madam did his UG and PG from IGGMC, Nagpur, has a huge experience of 19 years and practicing experience of 26 years. Madam is a life member of various organizations like IMA, AMS, VAPM, and has worked in a different capacities. Ma'am is a recognized PG and PhD guide and has many national and international publications. Ma'am has felicitated with Best Teacher Award in 2022 at DMMC Nagpur. Ma'am has delivered guest lectures in different teaching institutes, especially regarding the Vishakha guidelines. Now, with this, I welcome and once again request to deliver her talk on the subject. Over to you, ma'am.
Thank you so much, Ankush. At the outset, good afternoon to everybody. It's 12, I think. So it's good afternoon to everybody who is listening. At the outset, I would like to heartily thank the organizers for giving me this opportunity to have a dialogue with the postgraduate students all over. It's a my very favorite, close to the heart thing that I should have a dialogue and interactions with the juniors and the PGs, especially UGs and PGs, so that whatever concepts now they need to build about everything in the laboratory sciences, they need to be guided by us. I think so, because so many times now the things are so updated that the basics of it are usually overlooked and they don't go into the details of the basics. So thank you very much, organizers, for giving me this opportunity to have an interaction and dialogue with you all people. Thank you so much. With this, I will like to start, I think, my lecture on basics of the diagnostic techniques or the diagnostic tests, whatever we are performing in the laboratory medicine. The first slide we like to see is that just a minute, there is something. Hello, I think I'm audible now, and so there was a little bit of technical problem. So now let's start with our topic. As I will be talking about the laboratory diagnosis or the laboratory techniques or the laboratory medicine. Now let us start from the beginning, that as the patient comes to you with the complaints, whatever complaints he has or she has, patient comes to us. Then what we need to do is a proper diagnosis, which we do by so many things, the basic starting from the history that we will see later on. Then we do the physical examination, then we advise the diagnostic tests. There are a number of nowadays diagnostic tools or the equipments for performing different tests. And in this way, we arrive at the final diagnosis. As we arrive in the final diagnosis, then only we go for the therapeutic way. So to make a final diagnosis, we very much need all these laboratory techniques or the investigative data what we can see. Without that, it is very difficult to arrive at the final diagnosis. Now, as I talked about the diagnosis, now that can be a provisional and final, as we said. Provisional diagnosis we make as the patient comes to us, he tells us the symptoms, his complaints, what we call as symptoms. A number of complaints he comes with the pain in abdomen or headache or something like that, cough and cold, symptoms related to various systems of the body, CVS system, respiratory system, GIT system, or the CNS system. Accordingly, we form a little bit of our opinion that what the chapter must be, what the system the patient is affected and come with. And then we go for the physical examination. We see the signs in our physical examination, whether the patient is complaining of the palpitation, then you go for the CVS examination. If the patient is complaining of the breathlessness, then you have to see properly the lungs also and the heart also. Accordingly, whatever the patient is complaining and we have asked about the history, we go for the physical examination and look for typical signs. With these, we may arrive at times with the diagnosis, or we may need to have some investigations, they can either be radiological or the laboratory. Laboratory are the most important and the most common one also. And so with the provisional diagnosis, along with the aid or the input of the investigative data, we come to the final diagnosis. So this way we have to go along with it. Now this picture, you can see medico or the expert or consultant is taking the history. Now let me tell you, the history taking is an art. It's not that you just have to ask, kya hota hai, batao, batao, batao. It's not like that. And especially here when the patients are pediatric patients, then you need to make them comfortable with you. Not only pediatric, even the adult patient. When patient is coming to you, patient is in his own psyche. He is already affected, having so many complaints, so he may be irritable, he may not be very cooperative with you. The mothers which come with the children, they are also affected very badly because of the illness of their children, and they may come. So you have to make them comfortable to get and to draw the proper history out of them. They may not be able to give you proper history. At times, let me tell you, even the patient tries to conceal the history. Like when you go for the past history or the family history, like if the nowadays there is no so much taboo about anything, but like in the previous days when we were students, patient never used to give a family history of a tuberculosis. Somebody is suffering from the tuberculosis in the family, and somebody has had a past history of tuberculosis or any such infectious diseases, leprosy or anything like that. So you need to have build up the confidence with the patient and take out the history very properly from the patient. History does your half the work. Then you will always know what you have to look for in the physical examination. These are all the few very common, like somebody is taking blood pressure and auscultating the patient. But then you should know in the physical examination from top to bottom what you really have to see or look for. As a pathologist, don't think that you don't have to look for the patient. It's always our this is our motto that if the patient has come to you, you also examine the patient as the clinician is examining, and then you can always get something additional while you are examining the patient. Or when you are doing the FNA, we will be coming with this test later on. You first examine the patient properly. When you examine the patient does develop a confidence in you. He feels that yes, doctor is devoting his time to me, has dedicated his concentration upon me, and now whatever he will be depicting about my results will definitely be good. So he really becomes cooperative for me. Now, as far as the diagnostic tests are concerned, as in the layman's language or routinely, we call them as investigations. क्या-क्या investigations बताए हैं और या तो क्या-क्या investigations बताना है, sort of a thing, isn't it? So they come under imaging techniques, that is radiology. As you all know, X-ray chest is the absolutely routinely done investigation that everybody knows. In the radiology also, there is n number of update tests, and updating has become a very, very great up to the invasive radiology, MRI, CT scan, everything. That will be dealt with the radiology some other time when we will be talking about the radiology. Now today we are talking about the laboratory techniques. So about the laboratory medicine and the laboratory techniques, we will talk in the details. So let's see, what are the common tests which are told to the patient when he comes, or when you go as a patient, or when you take your patient to the doctor. The common tests which are told are on the blood or the urine examination, stool examination, or some body fluids examination, or the body tissue. We will come one by one with these tests. Urine, most commonly asked for as a urine examination. When even you will be telling as an Ayurvedic consultant that go and do your urine examination. In the PG, like when Ayurvedic PGs, you will be doing your PG sheet. So you should know that how you have to tell the patient the instructions before giving the urine for the urine examination. So here you can always know that the urine examination can be done either as a routine examination or culture sensitivity of the urine. Urine is usually told when there is a urinary infection or can be told for the other purposes also. If you are suspecting diabetes, you ask for the urine routine for the urine sugar. If you are suspecting some kidney diseases or the blood pressure or serious related diseases, you ask for the urine albumin. In that comes in the routine examination, chemical examinations, and the culture, as you know, it comes under the microbiology. So the culture and sensitivity will be talked in detail in that lecture. But in the urine routine examination, what we do is the physical examination, chemical examination, and the microscopic examination. So in the physical examination, you look for the specific gravity, appearance, viscosity, whether there is a turbidity or there is a clear urine. What is the color of the urine? Color of the urine can also tell you if there is a dark yellow urine, then you can always think of whether the patient is suspecting, must be suffering from hepatitis or not. Or there can be a number of drugs which can give this deep colored urine. So we have to know all these things before going into the asking for the urine examination. If you are giving some tablets for the urinary infection, then you can get the deep colored urine also. Then how you have to, a patient has to give a urine sample that you have to explain to the patient that ideally it should be early morning sample after the patient gets up from the bed. When he first goes for the urination, there is a concentrated urine of the night, whole night, and this urine a midstream sample. Ask the patient to pass a little bit of the first sample, and then the midstream sample he has to collect in a sterile container, which are available nowadays, and then he has to get the urine examination sample to the laboratory. Either it is routine or it is culture and sensitivity. At times, nowadays, it is not all that in the way woke, but before 24-hour sample used to be asked to collect for the protein estimations, 24-hour protein estimations and all, and that used to be collected with some preservative in it. So one has to ask for the proper collection of the samples so that the report or the result which you are going to tell should be really proper. And as I told you, container has to be sterile. Nowadays, there are commercially available sterile containers and there is no problem. Otherwise, you have to autoclave them and do them in that way. So, bit sorry for the interruption. Okay, so it has to be a sterile container. Then another is the stool examination, especially in the children. And like in this rainy season, the bacterial gastritis, gastroenteritis, and viral gastroenteritis, and all these enteritis problems are very common. Nowadays, we don't see cholera much. But the other infectious diseases are there, and you need to tell the stool. Again, you have to contain into the get the stool in the sterile container and go for the routine examination. There, where what you have to see for the ova and cyst in the urban population, you may not get it that much. But in the rural population, you do get the parasitic infections, and you have to see for the microscopy very nicely. Another one which can be routinely told is the semen analysis. Where do we advise the semen analysis? It is advised to the males of the cases of infertility. To the gynecologist, a couple goes that there are 1 year, 2 year, 3 year, and there was no planning, but still the wife is not getting conceived. So you have to investigate the couple. Mind well, you have to investigate the couple, not only the wife, for the cause of infertility. And nowadays, in this, it has been statistically proved that in this stressful working environment, the semen count of a male, normal average semen of count, sperm count of a male has come down a lot than the previous one. So in the cases of infertility, a husband or a male is asked to perform the sperm count, and then while performing the semen for the sperm count, to see whether it is normal count or oligospermia, that is a less count, or azoospermia, which is no sperm is seen, then you have to give them proper instructions that there has to be minimum 4 days of abstinence, that they don't have to wastage of the semen at least for the 4 days. Then you have to collect the semen as a way you have to reach the sample. You have to get the sample to the laboratory. Whenever you are going to get the sample to the laboratory, just before that you ask them to collect at the home and get the sample to the laboratory. In between only half an hour should have been gone, because we have to see the viscosity, what is the time taken for the liquefaction. All these things matter in the semen analysis. We are not going to go into the detail of all these tests. When we will be talking about that, today we are going to have an overall loop of all the tests. So whenever we will be going into the specific test, and we will be talking about the details of it, how we perform and how we do. But this much, at least as a consultant, we should know that if we are telling, or if we are advising this test, then what instructions we should give to the patient. Just a minute, I don't know what has happened. Just a minute. I'm extremely sorry, there is some technical problem about the slide share, and I'm trying to solve it. I've called my IT person. I just bear with me for a few minutes.
Don't worry, madam. It happens usually. It hangs on. Just press the downward button for next slide. It usually happens many times.
Sir, I'm doing that. Yes, I'm doing that. Somehow it has stuck up. Actually, I have confirmed it 4, 5 more times. Even Ankush is there, who has confirmed not this to happen. And very unfortunately, it has happened.
You click on the screen only. You click on the
Yes.
screen.
Yes. So you can see here, it is the disposable urine culture bottle. There you can definitely send the urine for the routine examination also. The name and the sex and the specimen sign, everything is written over here. And this is the container one has to ideally use. And you can keep it with yourself also, distribute it to the patients, give it to the patients, or you can ask the patient to collect it from the laboratory. Laboratory person do give. Now about the blood examination. Now you can see we perform on the blood routinely hematological tests, biochemical tests, and serological tests. So today we will be talking about the hematological test, biochemical test. The lecture will be taken separately on the different biochemical profiles. Now, as you know, there are many profiles, lipid profile and kidney profile, every thing, thyroid profile we all do. So it will be taken differently on that way. And today we will be talking mainly about the hematological tests all over. CBC and the peripheral smear will be dwelt in the detail in the next lecture. But the common hematological test we perform on the patient are CBC, that is complete blood count. It includes everything, right from the hemoglobin, routine counts, to the indices, to the PCV, to the graphs, to the RDW, red blood cell width, everything. Then we perform ESR, coagulation profiles if the patient are on the thinner, and or if you need to put the patient on the thinner, or any thrombotic patient causing to CVS or the blood CNS, we perform coagulation profile on the blood, and blood group and RH type are the routine. All these are the routine hematological tests we perform. So this is the phlebotomy. We ask the patient to go into the phlebotomy. So in the phlebotomy, what you are doing is actually you are taking out the blood from the vein. This is the anterior cubital fossa, you can see, where we put the tourniquet upside the arm so that the blood becomes stagnant and the veins become little bit tortuous, so that you can very clearly see the blood and take the blood into the vacutainers. I will show you this process of the taking out of or the withdrawing of the blood is known as the phlebotomy. Now I'll show you different vacutainers. These are all the different vacutainers where we collect the blood. And I will show you the next.
पानी पीता है क्या?
I'll request somebody has put the voice on.
वो कोई आदमी ने उसको घुमाने वाला
Kindly mute the voice. Whoever has
बुरे सुन इधर आ अभी
मैं नहीं थी लेकिन फिर भी करते थे।
नहीं है तो कर दो देख रहा
ये
है
नॉन टीचिंग का है सर।
उसी में सब है स्टूडेंट का अलग बना दिया
So these are
रिपोर्टिंग में जाएगा तो
vacutainers, and you can see all color.
नहीं वो सब
Here I will show you.
फोटो भी निकाले पूरे फैकल्टी को क्योंकि वहाँ पे वो भेजना पड़ता है
Has no anticoagulant. So
इसमें
when there is
जो
no
वहाँ थे ना वो टीचर की साइन रही पता नहीं सर कौन है अरे सब आए
excuse me.
सेंटर में चले जाना
Madam, you are the host. Now you can unmute them.
जो है वो
Please
साइन
unmute them.
सर दिवेकर मैडम के गुरुदे मैडम ये काम करता पीछे इधर एक पंचकर्मा
जो दिखे ना उनके साइन
जो दिखे वो ले ले बस उस पे चाहिए 15 नहीं
ऐसा कहीं नहीं
ऐसा नहीं जितने प्रोग्राम में थे
पूरे
उनकी साइन चाहिए जितने प्रोग्राम थे उनकी साइन
Madam, you can mute them. Madam, you are the host now.
नहीं क्या
गोरे आणि सरांच्या सह्या झाल्यावर तिथे टेबलवर एक फाईल आहे तेवढी कपाटात तिथे
Somehow I'm not getting that option to mute them.
Madam, click on the participant. Click on the participant.
Okay, I'll
You can see the participant.
और चाहिए
Yes.
And then there is a mic. You can unmute mute them.
यहाँ
Click on the mic.
बस एकदम अच्छा अभी आगे बोले तो कम से कम 5 साल
That is Madhvi Gaikwad and Mujawar
अभी
GP
जानना भी आ रहा
Talwar.
है नजदीक मतलब है
Madhvi-
Hello. Hello, I think I have successfully put the mute on them. Okay, fine. So now we were talking about the vacutainers. Now I have shown you different colors of vacutainers. This red cap, there is no anticoagulant. So there is serological examinations which are performed in the serology or the biochemistry. You can collect the specimen here. Then there is a sodium chloride, gray colored. For this sodium chloride anticoagulant is used for the glucose estimation. Then EDTA is the most common hematological anticoagulant, ethylene diamine tetraacetate, purple color, and all the hematological, most of the hematological tests like complete hemogram, CBC, ESR, by Winthrop, all these things we do perform on the anticoagulant blood of the EDTA. Then coming to blue one, it is 3.2% sodium citrate. All the coagulation profile studies are performed. A little bit of different proportion of blood and sodium citrate we do. Vistagreen ESR also. Then green colored is heparin. Usually bone marrow studies are done with the anticoagulant heparin when we draw the blood from the or the marrow from the marrow side puncture, then we have the heparinized syringe in it, and then the citrate is there, that is red, yellow color, and the second EDTA is the light purple color. So these are all the vacutainers, what we use for the different blood tests. While you are drawing the blood, as the PG in the routine, this hospital working also, when the junior residents are asked, usually it is the work of a junior residents to collect the blood and send the blood of the indoor patients. Outdoor patients, they do go to the phlebotomy room. Phlebotomists are very well made aware of what test blood they have to collect in which vacutainer tube. But the JRs I have seen usually clinical side, they are not much aware of it, and they, by mistake, they do take the different tests in a not very properly vacutainer, which may, please get it, which may hamper your result and your treatment. So it is very important, though it is seen very simple, one has to really follow it with a very religious way, that you will collect the blood in the same vacutainer. Okay, now coming to the, as I have told you different about the different anticoagulants, EDTA, sodium citrate, double oxalate, heparin, sodium chlorides, these are all the common anticoagulants which we use. Here what you have to know is that the proportion of anticoagulant and the blood, that also has to be maintained very, very properly. How it works? It works by the removing free calcium from the blood by chelation. Usually all these anticoagulants, they act on the free calcium, either by forming the soluble or insoluble compound with them, or by chelation as it is here. And then usually the hematological tests are done on the EDTA, CBC, PS preparation. PS preparation, if you want to do peripheral blood smear preparation, that you ideal peripheral blood smear preparation is done by the finger prick. But if you want to do it on the anticoagulated blood, when you are sending the CBC, you send a fresh prick, finger prick, PS. That is the ideal way. But if you have not done that, and if you are sending just the blood, then the person in the laboratory should know that this blood, till 4 hours only you use this blood for the peripheral smear, or the morphology of the cells will be distorted. Then obviously then you don't have to report all these distorted cells, because the cells are otherwise normal. So this will be false negative, whatever you will be, distortion will be reporting. So these are all, EDTA is usually not done in the coagulation studies. So don't go by the shortcuts. अगर coagulation study करना है तो you have to ask for the citrate bulb. अभी ये तो बचा है, इस पे कर लेंगे, is not the thing which we do. So whenever you will be working into the laboratory as the laboratory expert, don't do all these things. Sodium citrate is another one. Coagulation studies, 1:9 proportion for the Vistagreen ASR, 1:4 proportion. You have to take, I mean the one coagulate, 1% reagent. Then
रिटर्न येतानाचे जे टोल होते ना, तर तुम्ही जातानाचे कसे 2 पाठवले, तसे येतानाचे पाठवा ना.
I will again try to mute the participants. I think I had done Some new must have joined. I really don't know. There is another double oxalate, you know. These proportions has to be proper, and this is double oxalate. The guan, sodium, potassium tries to shrink the RBCs, ammonium tries to inflate the RBC size or the cellular size. So in a way, it goes to the balance of it. So whenever we are preparing anticoagulant, also it is very much essential to follow the rules. Then coming to the heparin and the sodium chloride. Sodium chloride is used for the glucose estimation. As I have told you, bone marrow studies, heparin is used. There is something like specificity and the sensitivity of the test. You really don't have to know much about it, but still a word about it because we are talking about the laboratory test. So what is the sensitivity of this test? It is the ability of a test to correctly identify the positivity of the people with the disease. Highly sensitive means very few false negatives. And the specificity is the ability of the test to correctly identify the people without disease. So highly specific means very few false positives. Usually sensitivity and specificity are inversely proportional to each other. Positive predictive value reflects the proportion of the people with positive test result who truly have the outcomes of the interest or the disease. And negative predictive value reflects the proportion of the people with negative test results who truly do not have the outcome of the interest or the disease. So specificity and see, you should also know the what is false positive and false negative also. Suppose there is a pregnancy, urine pregnancy test which has come for the testing, and if it is negative, but if it, so आगे जाके patient को positive आ जाता है, so it was a false negative because it was given before that particular time where the HCG runs into the urine, comes and finds the way into the urine before 6 days or the before 5 days if you do. So that was a false negative. So similar way, you can always have a false positive tests also, like a sugar, urine sugar if you do, the Benedict's test. If sugar is there, the color change will be there, but there are the few edibles which if the patient has taken, that may change the color. One should be very much aware of that while doing the test. Coming to the body fluids, which are the body fluids which we really do commonly is the CSF. In the patients who are admitted, indoor patients of meningitis, or if the patient is unconscious, coma, or somewhere like that. So cerebrospinal fluid we usually test. We draw the fluid by lumbar puncture. Lumbar puncture is done with, in the third or fourth lumbar space. One has to keep the patient's spine very good convex way. Then you feel it before going to the cerebrospinal fluid withdrawal. You have to do the fundoscopy and see if the CSF pressure is not too high. You have to see that the CSF pressure is normal. Then you put the LP needle and the CSF starts coming drop by drop. So you have to examine the CSF, whether it is a viral meningitis, bacterial meningitis, or the tubercular meningitis. Same way, it is the pleural fluid. You draw the blood in between the ribs. You have to see the maximum point of dullness where that fluid must be there accumulated. You draw it and again see for the physical examination, chemical examination, and the microscopy examination. Pleural fluid is most commonly seen for the tuberculous pleural lung, and then there you can see the cobweb formation and the lots of lymphocytes into the microscopic examination. Same way, peritoneal or the ascitic fluid is drawn, and usually peritoneal and the ascitic fluid we mostly do for the malignant cells to see if the ovarian malignancy or any intra-abdominal malignancy is there. Exfoliated cells on the particular primary sites are distributed, or otherwise also you can see for another few of the medical conditions. But routinely nowadays, when the peritoneal or the ascitic fluid comes, we have to concentrate on the presence of the malignant cells. Pericardial fluid, hardly there is any condition where in India we can go for the pericardial fluid. We don't touch heart in this way. As I told you, hematological test, CBC, peripheral smear, ESR, blood group, sickling is also there. In our part, there is a rampant sickling we can see, and we do the sickling, raw test, screening test, which are solubility tests. Then we go for the electrophoresis, or then we go for the confirmation for the HPLC. And the coagulation studies, I have told you whether you have to put the patient on the thinner, or if the patient is on the blood thinner, that is on the anticoagulant, then you have to perform all these coagulation tests, PT, PTTK, APTT, all these things you have to do. Either you do it by manually, or you have an autocoagulmeter and you do it there. CBC and peripheral smear, we are going to dwell in a detail in the next chapter. Blood group, in the ANC patient, we always do. If your patient is going to need a blood transfusion, again, you have to do the blood group and all these things. Sickling, we are doing projects on the sickling, newborn sickling, ANC sickling, sickling in the marriageable youth screen, marriageable youths, and this sickling will definitely prevent or reduce the incidence of the sickles in our population. We need to do it, and there is a national program for it, and one has to really take the projects for sickling, and it is a national project also. You get the notice centers and you get all the facilities and you can do it. This is the way of drawing the peripheral blood smear. Here they have taken the drop of a blood. Then you can see there is one slide this way, glass slide, the another spreader glass slide. It is known as a spreader. They have kept it in the 45-degree angle. Then you keep it, come into the contact of the drop of the blood. Let that drop properly get spread along the edge of the spreader, and then you have to draw it this way, and this is the final smear which comes out, peripheral blood smear, because you have to smear, you have taken out of the blood in the peripheral circulation from finger you have done, or from the anticoagulant vein pressure you have pain you have taken, the blood phlebotomy has done, and this is the head and this is the tail of the smear. This is the middle part. Here is the tail portion. Here you can see mostly it is a one cells thick smear, and you examine the and get the report from this part. One has to know how to draw the smear. It's an psychomotor skill, and as you will be doing it more and more, you will be able to do it. It is, as I have always told you, that as a JR, you need to send the smears to the laboratory, and if you can do it from the finger prick, then it is the best smear to report. And the report you will get on such smear, ideal smears, are the best reported smears. So many situations or the conditions you can always suggest on a smear, whether it is a normal smear or you are finding something abnormal in that smear. Then we come to the body tissues, that is cytology or the biopsy. We do cytological studies. Exfoliative cytology is there, or the aspirational cytology is there. You all must have heard about the pap smears. So pap smear is an exfoliative cytology. All the genitourinary smears or the genitourinary lining, it is in the labile cells. They are in a very great turnover, completely. I mean, they are in the routine turnover. Their age is very light. The basal layer is coming up, becoming superficial layer, getting shade off in the squamous lining, and again the basal layer is coming up. So likewise in the respiratory one. The exfoliative cytology, the cells which are coming up or shaded off, you take onto the smear and make the pap smear. That is a papinoculon stain. The scientist papinoculon has invented it, and you see a screening of the cervical cancer or anything like that you are doing on it, even the infectious agents. In the aspirational cytology, what you are doing is that you are aspirating the body fluid or into that tumor fluid or the mass fluid or the mass tissue under the vacuum, and then you are spreading it and see the cells. You are actually studying the different individual cells. Like in the biopsy or surgical specimen, where we call it as an histopathology or the surgical pathology or the autopsy pathology, like that, So where we are actually putting the tissue, we will see in the later slides what we are actually doing, and see the tissue as such in the micro thin section. So this is the peripheral smear, normal peripheral smear. These are all the RBCs. What you are seeing, these are the RBCs. This is the central vacuole, no, not vacuole actually, unstained pale, this thing area. This is 1/3. Ideally, it should be 1/3. And the stained hemoglobinized area should be 2/3. Why it is like that? Because the RBC shape is biconcave. It is a biconcave. So in the center, it is depressed like that. So obviously the hemoglobin content is less over there. And if this 1/3 polarity is more, then it is hypochromia, we call it. Severe mild hypochromia or the severe hypochromia. Then these are all the WBCs. This is band cells, this is monocyte, lymphocyte, eosinophils, basophil, neutrophil. Whosoever will be doing the post-graduation in the pathology need to know all these things. And if you are not doing it in a pathology in some another consultation area also, then you need to know what you are sending, what exactly you are going to expect, or what exactly the laboratory consultant is going to see for you. So a basic awareness of the knowledge of these things is very much essential. Now, you can see here the peripheral smear where you are not seeing the normal cells. They're all the premature or abnormal cells. So this must be something leukemia, acute leukemia. These are all blast cells you are seeing. And here also RBCs you are seeing. Here, this is known as Role formation. In the multiple myeloma, you find a lot of Role formation because of the myeloma protein in the plasma. So by looking at the RBCs, their structure, their way of distribution, and the WBC, you can tell n number of things to do. You can suggest n number of things to the consultants where you have to go for and see for, and what can really be the abnormality can be. This is chronic myeloid leukemia. Again, these are all the premature myeloid cells. These are all the cytochemical reactions in the acute leukemia, like that. What we saw here, these all are the Leishman stain or the Giemsa stain. And if you perform the special stains like myeloperoxidase, Sudan black B, specific hysteresis or non-specific hysteresis or the past cells, they all can identify very aptly myeloblast, monoblast, or variable post. And you can, in the acute leukemia, you can divide them as either the lymphocytic origin or the myeloid origin. And this is the way we used to do that. Nowadays, it has not really, this is the myeloperoxidase. These are all the myeloid cells positive. You could have seen in the this one. These are all those cells which are in the myeloperoxidase are looking like this. So these are the special stain. They are excluding the lymphocytes and they are giving the picture of a myelocyte. So you know that it is a myeloid origin leukemia. But now it has all been replaced by the flow cytometer. This is the flow cytometer. How does it work? It works on the, like there is a moving one directional fluid stream where the cells are moving and a laser beam is passed through and there is a scattered light and a fluorescence emission is there, and it is measuring and studying the each cell individually, and scatter is given. These are all the scatters. This is the side scatter, this is the forward scatter, and this is the way normal smears. These are all the granulocytes. Then these are all the lymphocytes, their placement and their proportion is like that in a normal one. This is a very rapid analysis where you get the diagnosis, not done very, very commonly, but yes, nowadays it has become common in the patients of leukemia, lymphoma. Now here you can see, these are all the granulocytes precursor. Myeloid cells. So the scatter has totally changed. These are all the blast cells. You could see the previous slide. how the scatter was there. And now look at this slide, the scatter is like that. So immediately you can know what type of leukemia is there, what type of leukoproliferative disorder is there, what really therapy you need to confirm. And it is very important, the time is very important for this leukemic patients, that you need to start the therapy at the earliest. So all those special stains have been replaced nowadays by the flow photometer. The flow cytometer is not routinely available with all the laboratories. The referral laboratories or the standard laboratories do have the flow cytometers, and when we refer our patient there for the special treatments, one knows that everything is there and the patient does all these things. Now this is the one, we are seeing is the grossing station. We are coming to the tissue biopsies, histopathology. Here this is the grossing station, this is the light, this is the sink, and here we keep the tissue, cut it, all the cutting instruments are keeping here. This is also, there is a light, there is a water source, and we do the grossing of the specimen over here. What is grossing? Actually, grossing is known as the operation on the cut tissue. So either you get the biopsy there, you get the whole biopsy specimen, which is because it is very small for the processing, or if you get a larger tissue like a mastectomy specimen after the carcinoma breast, a patient comes, you do a cytology, give a report, or true cut biopsy, give a report as a carcinoma breast, and then you get a mastectomy specimen where you get the whole breast with the axillary tail with the involved lymph nodes, and then you cut it properly, that is gross it properly, get the tissue, get the tumor where it is, get the nodes, and then you have to take all the representative sections and proceed it or the process it for the next process in this histokinete. This is automatic histokinete. These 14 jars are present here. Here you put the alcohol in the increasing concentration and other xylol and other preservatives, and get those whatever cut representative sections, process through it for the 15 hours or 12 hours accordingly, and then you process it further. So the basic content is tissue should not get putrefied. It should be properly maintained. The morphology of the tissue should be maintained so that you can able to know it in the microscopy, what you are dealing with, which tissue you are dealing with, and what abnormality you are seeing here. Now, like here you are seeing the breast tissue. This is the duct. These are all the lobules. This is the normal one. This is the duct. And these are adipocytes, that is the fat cells. These are acini or the alveoli. This is the normal breast section. When you see, these are all the fat cells in the breast, and this is the section you see in the normal breast, and this is the section you see into the carcinoma breast. Now you can see that there is a whole architecture is lost, normal architecture is lost. These tissues, these cells, tumor cells have spread everywhere. They have come out of the alveoli, they have come out of the duct, and they have spread into the whole stroma, and you can see. And accordingly, you can type the cancer and give the details of the cancer report to the clinician or a surgeon so that the exact therapy can be maintained. For the exact therapy, oh my God, okay. For the exact therapy, you know, you need to go for the IHC markers also at times, immunohistochemical markers also, or the next generation sequencing you do, what type of mutation has been occurred in the DNA that you have to do in the tumors, and accordingly they put the patient on the particular therapy. The things have gone far away so that you can really easily pinpoint the exact defect and put the patient on the very specific therapy so that the patient do have a maximum profit of it or benefit of it. In the cytopathology, we have already seen about the exfoliative and the aspirational. In the exfoliative, these are all the images of the cervical epithelium. As I've told you, squamous epithelium, this is the basal layer. These are getting exfoliated. This is the infected cell. This is low cancer grade. This is little bit of the higher cancer grade. This is carcinomosity. You can see the abnormal cells are going up. And then ultimately in the pap smear, this is the area from where you take the pap smear. This is the normal cervical os. This is the abnormal cervical os. You can always see here you are seeing these things. And then you can see this is the normal pap smear. These are all the superficial squamous cell. In the abnormal pap smear, how these cells have changed. This one you can always see. And this way, this is of course the severe one. In between you get lot many gray zones also. But then this is just for your understanding. I'm showing the cell studies, how we perform. And this is the aspiration. This is the breast. This is the tumor. You aspirate the fluid, make a smear out of it. Here you can see we have make a smear out of it. And now these are all the abnormal cells in the carcinoma of the some organ. This can be breast also. You can see that each cell is different. That is known as anisopoikilocytosis. Each cell is different. These are all the nuclei. This is the cytoplasm. Look, here is the mitotic figure. Every cell is a different. They are like a terrorist cell, I always say in my lecture. And this is the way we do for the cytology. Histology we have also talked now. The upon new coming नहीं जो आ गए हैं वो तो newer branches are medical genetics, which are the branch of human genomes dealing with the relationship of the hereditary and the disease, which the diseases which runs in the family. They see nowadays newborn estimation, newborn genetic studies is also, or the ANC genetic studies has also become very common and the people are doing it. Then molecular pathology deals with the abnormalities at the DNA level, that is done by in situ hybridization or PCR test. PCR test now we all know because of the COVID, there is a PCR or the reverse transcript is also RT-PCR. PCR is a polymerase chain reaction and you can detect the genome in the absolutely very little quantity out of that whatever specimen you take of any microbial agent or any other, if you want to have a human genome for some abnormality, you can detect it. So PCR tests have become very common. For TB also CBNAT we do nowadays. So molecular cytogenetics is molecular biology combining with the cytogenetics also, which is done. They are done in a very few cases, not very commonly, but we should know about all these upcoming branches or upcoming updated things what we are still doing in the laboratory medicine. There are n number more, but I don't think this we can really have a time. I think it's already getting one. So I don't think I will be bombarding more on you. This was a very few or the overall review of whatever usually we do into the laboratory medicine, or we should do as the patient comes to us. For the next of the lectures, I think we'll be dealing with in detail of it, like CBC and peripheral smear, like in a common biochemical profiles, what we do, hormonal profiles, routine biochemical profiles, and for the culture sensitivity in the microbiology, what we do, that will be well with in detail by my colleagues. I hope, I think I have not hammered much upon you and you have enjoyed, and thank you for listening to me. Thank you so much.
Thank you. Thank you very much, ma'am, for your precise, very informative and elaborative lecture on basics of diagnostic technology. I hope our PGs got benefited a lot from the lecture. And I am thankful to you, madam, for spending time with us on our platform on the entire behalf of our RVPG organization. And I am quite hopeful that in future also, whenever required, we get your guidance. Once again, thanks. Thank you so much, ma'am, and thanks to all audience for their active participation. If anyone have any query or questions, they can ask, please. Anyone having doubt or question?
Ankush, I think there is something in chat box. You can view the chat box.
Yes, yes, yes.
Ma'am, in case of hepatitis, so if we want to rule out whether this was a past infection, so the
Yes.
core antigen is what we should check, ma'am.
Yes,
It's A, B, C, D, E, whichever.
say hepatitis, you want to know the past infection. So you can always go for the antibody test. We all are doing hepatitis B antigen, hepatitis C antigen, qualitative, semi-quantitative, and the quantitative also. It comes under the microbiology, and they do give you the screening test also and the furthermore test also. You can always send the blood and get the things done.
Ma'am, I wanted to understand is now there is a patient.
The hepatitis B and C.
Okay, the most commonest first to rule out B and C. And what I'm saying, my understandings, I may be wrong, so please correct me. I'm thinking HbSAg, what we do is just the basic screening. Only if there is a active infection, it just screens.
It is a basic screening. It is a basic screening. If it comes positive, then you have to go ahead for the other tests. You have
And
to
if the infection is over 1 year, ma'am?
see if the infection is there, it is there, antibodies are there, then you have to see whether the infection is active or not active. And basically we go for these all tests in the blood transfusion also, in the blood banking also, because you cannot give or transfuse these bloods or anywhere. Like ANC patients also, you go for these tests, and if it comes positive, then you have to go for the next tests.
So you're telling me simply do surface antigen, which be antibodies hai, so we will be able to detect. That is enough.
Most common.
Even past infection.
Yes, yes, yes.
Okay. Then or no need to do like antibody IgM, HbSAg, antibody IgM.
There are antibody IgM, IgG, which are recent antibodies, past antibodies, few viruses also. There are also toxoplasma, Epstein-Barr virus, or the ANC. What we see, we do have these antibody tests also where we perform the very routine. We do have. It is mattering. Wherever it is mattering, we have those tests and we perform. They're all serological tests.
Good. So is there a relation between this ANA blot 17 May if RO52 antibody is positive and liver enzymes are consistently high for more than a year in a patient? So is there a relation? So trying to understand autoimmune liver pathology.
See, madam, if there is any such patient, then we have to think about that specific patient in detail. Overall, we cannot do any statement about such things. If you have got any patient, then you get to me into the detail of it, and then you can see what.
Okay.
Okay.
Sure, ma'am. Sure. Thank you.
Very good afternoon, ma'am. Hello, am I audible? Hello.
Yes, you are audible.
Very good evening, ma'am. It was a very wonderful and very much informative session. I have one question. For how many days does a Vidal test can come positive after a patient has been treated? Fully completed treated, but then sometimes we go for a blood sample and always I have one patient who is always with Vidal test positive 140 160 like that.
See, 140 is not a very significant titer. The thing is that after 8 days or after a week, you do a
Ma'am, voice. Ma'am, your voice is not. No, you are not audible.
Actually, it is not.
Yeah. Now it's okay.
Okay. See, Vidal test is usually done after 1 week or 8 days of the fever.
Yeah.
Then only it is coming positive. And what we do is that, usually in the practice also, positive is positive. Actually, it is a serially increase in the titer which is taken as a positive. Usually we don't do that, and then it has to be a significant titer. 1:40 is not really a significant to call it as a positive.
Okay, okay.
And this, you see, if you are doing repeatedly the vital test on that particular patient, and if it is increasing, then it will be significant. If it is not increasing, then
Okay, it can come positive like up till 1 year also, 1 year or 2 year, 160,
theoretically
140.
what they say, I really don't know. Because it all comes into the serology and the microbiology. But
Yeah,
in
yeah.
my 25 or 26 years of the practice, nobody
Yeah.
has come after the 1 year for the Vidal test.
Actually,
of the previous infection. Let me tell you, of the previous infection.
Yeah, yeah.
The patient is suffering from PUO, that is pyrexia of unknown
Yeah,
origin.
yeah, yeah.
Again, and then you are doing it, then it matters a different thing. But the old infection coming positive in a significant titer for a continuous 1 year, at least I am.
Okay. Thank you so much, ma'am. Really nice session, very informative. Thank you so much.
And very short. And so many people must be having so many curiosities to know the deeper part of it, which I told you that if you take each and every test, then you can go for the 1 hour discussion. Possible here.
Anyone having query?
Ankush, I think we can wind up now. We can take one or two questions, just that's all, then wind up. It was a very nice session. At least madam has instigated, infused the interest among the our PGs, and hope the tempo will continue with subsequent lectures.
Thank you, sir. Thank you.
Thank you so much, madam, and thanks to all delegates for their active participation. Can we end the meeting, sir? Dr. Waghe, sir, can we end the meeting?
Yes.